Hello everyone, and I hope all of you are doing perfectly fine. So today I'm here again with a rare case, how we approach it and arrive at our final diagnosis. So this case basically I'm discussing to give you an insight like how we approach to a case when it comes for us for a tentative, provisional or definitive diagnosis. Fine. So this case In this case, a 40-year-old woman, she presented with a slow-growing asymptomatic mass and it was over the right parieto-occipital region. Okay, there was no history of trauma, headache or convulsion in the patient, and when we examined the swelling, it measured approximately 282 centimeter and was slightly fixed, firm, non-tender, and it was non-fluctuant. See, when you describe a swelling, you need to describe the location, size, and then how consistency of the swelling, whether it is, and the condition of the overlying skin if you can. There was no discharge or punctum associated with this swelling. When we did the lab investigation, it was normal. The hematological and biochemical, the commonly done tests, all the parameters were within normal limit. X-ray of the skull was done and it showed bony calvaria with no evidence of any abnormality in the bone or any evidence of fracture. CCT, however, when it was done, it showed evidence of a soft tissue enhancing mass over the right parieto-occipital region. और उसके नीचे जो soft tissue swelling थी scalp पे, उसके नीचे जो bone था, that showed mild erosion in the corresponding region. Underlying brain parenchyma was perfectly normal. So see, this is the clinical picture. जो round मैंने mark किया है, you can see a छोटा सा 22 centimeter. It was a soft tissue swelling which was in the right parieto-occipital region. इसके underlying brain parenchyma was normal, but जो जिस skull पे ये है cutaneous lesion, that skull was showing evidence of erosion on CCT. See, this is the CCT image. Where the white arrow is pointed, you can see एक soft tissue enhancing mass है, उसके underlying जो skull है वो थोड़ी सी eroded है. Fine, but the intracranial, the mass was, the brain matter was perfectly normal. No involvement of the brain parenchyma. So we did FNA. FNA हम कौन से lesions के करते हैं, which is easily accessible. So this was very easily accessible. We put the needle and we did the fine needle aspiration cytology. And when we made the smear and stained it with PAP and GIMSA stain, after that we see it under microscope. So what we saw, the smears prepared were highly cellular. Cellularity हम देखते हैं जब हमारे cells बहुत मिल रहे होते हैं, ठीक है? And it comprised of cluster sheets and whorl pattern में. So this word is very important here. Tight ring जैसे ना whirling of the cells होती है ना, whorl pattern में cells थे, and also singly skated epithelial cells. And when we examine थोड़े high power पे when you go, then you what we saw, that these cells showed mild pleomorphism and were round to oval with eccentric nuclei. I'll show you the image, with fine granular chromatin and moderate amount of cytoplasm. And in fact, we noted intranuclear inclusions also in these cells. The tight whorls of those cells were seen, no necrosis or mitotic figures, so not a malignant feature. So we gave a impression of cutaneous meningioma. तो हमें जो cells मिले थे whorls में, clusters में, sheets में, those were meningoepithelial cells, and we got intranuclear inclusions also. ठीक है, तो cytomorphological based cytology don't give you a definitive diagnosis but give you a provisional diagnosis. So based on cytomorphological findings, our diagnosis was cutaneous meningioma and clinical follow-up was advised. The neurosurgery department, they advised for neurosurgical intervention. So see, before we move on to this gross specimen, these are the images. So figure A में आप देखो, these cells are showing एक ring जैसा बना हुआ है, that is a whorled type 3D whorled structure of meningoepithelial cells, very characteristics of meningioma. ठीक है, then you can see other, आप sheets में भी cells देख रहे हो, और figure A के जो inset होते हैं, जो छोटा box बना हुआ है, वहाँ जो आप cells देखोगे, it is showing a world of meningoepithelial cells. ठीक है, फिगर बी में जब हम थोड़े हाई पावर पे जाते हैं, सेल्स के इंडिविजुअल सेल्स की मॉर्फोलॉजी इज मच क्लियरर इन दिस. सो व्हाट यू सी हियर इज smears showing meningoepithelial cells with mild pleomorphism, round to oval shaped nuclei which is eccentrically placed, and nuclei के अंदर आप देख सकते हो intranuclear inclusion. उसका मैंने inset में I put an image. put the image, and here you can see छोटा जो cell है meningothelial cells, abundant cytoplasm, round to oval nuclei eccentrically placed, and you are getting intranuclear inclusion in this. Fine. So this tumor was surgically excised and sent for histopathological evaluation. Then we did multiple sections. जब हम histo करते हैं तो we say it section. जब आप cyto देखते हो that is smear. Fine. Multiple sections showed fibroadipose and fibrocollagenous tissue with interspersed whorls, nests and syncytial sheets of meningoepithelial cells. In fact, we noted a focus of microcalcification also. Histo पे हमने confirm किया diagnosis was similar to your cyto findings, that is cutaneous meningioma. And we also moved ahead with immunohistochemical marker to give a definitive diagnosis. So we took vimentin, epithelial membrane antigen and S100. These all three were positive. These are very specific for your cutaneous meningioma. So diagnosis, our diagnosis, final diagnosis which we gave was cutaneous meningioma, or you can call it as cutaneous meningothelial heterotopia. Present where it is not present, should not be present normally. Fine. So these were the section. इस section में आप क्या देख रहे हो? Extensive fibroadipose और fibrocollagenous tissue है, ठीक है? And then what you are seeing, nests and syncytial sheets of meningoepithelial cells. और बीच में dark जो blue है, that is your microcalcification. In fact, this I put in your inset box में देखोगे right hand side में. This is a microcalcification, the image of microcalcification which I have put here. So see, this is a hyper view. इस view में भी हम क्या देख रहे हैं? These are monomorphic cells है, mild to moderate pleomorphism with round to oval nuclei है, which is eccentrically placed. Fine granular chromatin है, abundant eosinophilic cytoplasm है, ठीक है? So very characteristic of meningoepithelial cells. So now we move on to the IHC. Vimentin positive है, epithelial membrane antigen positive है, then you have S100 positivity. So all these three IHC marker were positive in our case. So our final diagnosis was cutaneous meningioma or cutaneous meningothelial heterotopia. Fine. So few words about cutaneous meningioma when you have diagnosed it. So see, overall meningioma बहुत common होता है. This is a common neural tumor in adult, approximately about 15 to 20%. Commonly कहाँ arise करता है? This is seen in intracranial and intraspinal regions. The cutaneous meningioma are rare, and since these are accessible to FNAC, so they pose a diagnostic challenge according to the location where it is found. So these are ectopic meningothelial cells. Meningothelial cells तो meninges, you can say meningioma जहाँ होता है normally intracranial, intraspinal वहाँ होगा, but ये ectopic है. Dermis cutis usually on the scalp. ठीक है? So this case of ours was reported as cutaneous meningioma of parieto-occipital region. Basically we are emphasizing, first point is emphasizing the importance of a simple test, that is final aspiration cytology, and many differential diagnosis in pathological evaluation of scalp swelling. जब आप scalp swelling की FNAC करते हो, then you need to keep this differential in your mind. Yes, this can be cutaneous meningioma, so you should know the morphology of the cells. So these ectopic meningioma, these are rare tumor और ये derive होता है meningothelial cells से ही, which are located in your dermis or subcutaneous tissue. Usually scalp में होता है and it can be acquired and congenital both. तो ये कैसे form होता है, ठीक है? So there are many theories which have been put up regarding this origin of these cutaneous meningioma. So it can be an extension through any defect foramina or the defect, ठीक है? कोई वो है connectivity है. Then they may arise from embryonic arachnoid cells, multipotent mesenchymal cells anywhere in the body. Third, it can represent metastasis from primary or supraspinal meningioma. ठीक है? Lopez et al. In 1974, he had divided cutaneous meningioma into three major types. Type 1 तो congenital, usually seen on scalp. Paravertebral region में, the origin was considered to be ectopic arachnoid trapped in the dermis and subcutaneous. Type 1 जो होता है ना, that is usually confined to your subcutaneous tissue. No connection from the underlying areas or anything. So this has actually studies में देखा गया, this has better prognosis when you compare to your type 2 or type 3 meningiomas. फिर type 2 cutaneous meningioma is a ectopic soft tissue meningioma जो extend करता है और to the skin surface, or it can be seen around your eyes, ears, then your nose, mouth. So no associated meningiomas of neuroaxis were found in this case, are found. So type 2 is ectopic rest, you can say. Third होता है जो extension into the dermis or subcutis from the meningioma जो neuroaxis में हो रही है, मोर कॉमन इन अडल्ट है ये। कोई बोनी डिफेक्ट हो रहा है जिसकी वजह से वो अंदर से बाहर, और एनी सर्जिकल रीजन से जिसमें कोई फिनोमेना क्रिएट हुआ हो, तो इट कैन कम आउट थ्रू माइनर होल, और सम दीज सेल्स कैन कम टू द क्यूटेनियस और सबक्यूटेनियस रीजन। सो दीज आर 3। टाइप 2-3 में डिफरेंस यही है। टाइप 2 जो होता है, नो एसोसिएटेड न्यूरैक्सिस मेनिंजियोमा इज सीन, एंड इन टाइप 3 यू हैव a connection, so neuraxis involvement, neuraxis meningioma is there which is extending because of some defect to the cutaneous or subcutaneous region. Wagner et al ने भी similar case report किया था हमारी तरह ही, but in that case the patient had a bony defect which led to migration of the meningothelial tissue up to the scalp region. In fact in our case ये ectopic meningioma कह सकते हो, क्योंकि वो mild erosion जो है that is not creating a connection from your meninges जिसकी वजह से वो बाहर आ जाए, ठीक है। So more of a type 2 ectopic meningioma था हमारा case. So these tumors have to be differentiated. So as I said कि एक तो simple procedure का importance है इस case में, and then second is कि differential diagnosis which you need to keep in mind while you are seeing the slide of cutaneous meningioma or seeing the slide of FNA of scalp swelling. So कोई भी appendageal tumor हो, epithelioid spindle cell sarcoma, peripheral nerve sheath tumors like your neurofibroma, schwannoma, squamous cell carcinoma, hemangioma, giant cell fibroblastoma, loads of differential you need to keep it when you examine in swelling in the scalp. ठीक है। सो हमने क्या देखा, इस ट्यूमर में मोस्टली तो सेल्स होते हैं वो शीट्स, लोब्यूल्स और नेस्ट्स में होते हैं। इंडिविजुअल सेल्स व्हेन यू कम टू डिस्क्राइब इट, दीज आर ओवल टू पॉलीगोनल मेनिंगोथेलियल सेल्स, वर्ल्ड लाइक अरेंजमेंट्स होती है, सैमोमा बॉडीज और कोलेजन। जो माइक्रो कैल्सिफिकेशन थी, वर्ल्ड टाइट वर्ल्ड पैटर्न्स हैं, इंट्रान्यूक्लियर इंक्लूजन्स हैं, दीज हेल्प यू इन क्लिंचिंग द डायग्नोसिस। IHC में हमें देखा कि Vimentin, epithelial membrane antigen S100 were positive, and these we can put other markers also. We need to put to differentiate that this is not. जैसे हमने cytokeratin marker लगाया, इसका मतलब it excluded the epithelial origin, ठीक है। CD34, 31 हम लगाते हैं कुछ vascular origin के लिए। Desmin SMA लगा सकते हो to rule out any myogenic differentiation, ठीक है। So different treatment क्या है meningioma का? It's a complete surgical excision. जो small है, asymptomatic है, simple excision can be done. In our case, it was a very well localized soft tissue swelling with no underlying defect. So this lesion was completely excised and sent for histopathological examination. As I said, type 1 is found to be having a better prognosis as compared to type 2 and 3. 3 has difficult, poor, comparatively bad prognosis because उसमें connection होता है, तो you need to rule out कि कोई meds और कोई connectivity तो नहीं है from where जो वहाँ कहीं दूसरी जगह से the meningothelial cells are coming and resting in your cutaneous or subcutaneous tissue. So presence of any deep-seated neoplasm should be ruled out क्योंकि उसके लिए different mode of intervention होगा. So to conclude this case, see, this case emphasizes importance of a basic test, that is FNAC, in conjunction with histopath, and importance of your immunohistochemical marker. That is very, very important in labeling any rare tumor if you can put it. Fine. So, and also when you are examining a soft tissue lesion in head and neck region, okay, and when you get a chance to do the FNA, so then you have to keep it as an important differential diagnosis of cutaneous meningioma. And also radiology is important to rule out any bony defect or any underlying connection or neuraxis or meningioma of your intraspinal or intracranial meningioma. Okay? So that will help in like making a proper decision to the surgeons. So this case of ours was published in Indian Dermatology Online Journal. Is a very good journal. And this case we reported in Dr. Ramanolaya Hospital when I was working as senior resident there under our HOD Dr. Meenakshi Bhardwaj and Manju Kaushal ma'am. She was their cytopathology head that time. So this case was published. This is a very rare case, and we could nicely work on it. These are few references. Thank you so much for your patient hearing, and at last I would like to request you all to please like, subscribe and share this channel. Thank you so much.